So one person says, I'm currently in remission. What can I expect in my future? How long does remission last? And is treatment after remission the same as initial treatment?
So that is very dependent on what a patient receives. So there's different a lot of our treatments, we look at median times to a patient when patients have relapse. That can be a little bit different for single agent antibody therapy versus antibody in combination with chemoimmunotherapy, for how long that treatment remission lasts. As far as, we don't typically reuse a treatment once we have used it before, although there is data in follicular lymphoma when patients receive like single agent antibodies, so rituximab alone, if they do well with that single agent immunotherapy for a long period, they may receive retreatment with just that, so long as they don't have disease that requires more aggressive treatment.
Okay. So is that more likely to happen then if a patient maybe wasn't refractory to it, if they just stopped using it for some reason? Would that be more common for that to happen, to go back on that same drug?
So with rituximab, we use it alone and in combination. So there are some patients that don't necessarily have what we call a large tumor, and they don't have a lot of lymph nodes, or they don't have large lymph nodes, but they might be symptomatic from them, or the location might be problematic. And so once your lymph nodes get a certain size, they usually don't have as good of a response to single agent antibody therapy. But there are patients who have small, lymph nodes that aren't as big, but again, are causing a problem, that can get completely, you give a short course of the rituximab and it can last for a very long time. And then you would consider again using like a short course of that rituximab. The chemotherapies we don't reuse, chemotherapy for the most part. Some of that, for a while, there was like bendamustine, if patients got 5, 6, 10-year remissions out of it. Sometimes they would re-get that chemotherapy, but I think we've just seen so many newer therapies approved in the last 5, 6 years, like the bispecifics, the EZH2 inhibitors, lenalidomide, CAR T. We had different PI3K inhibitors available for a while. And so I think it was just that you had the ability to offer a patient something that they never had before. And that is, more appealing.